Hello everyone and welcome to another pediatric lecture. Today we will speak about pylorospasm. So pylorospasm is a functional disorder where the pyloric sphincter, which is the sphincter between the stomach and the duodenum, will undergo intermittent and intense spasms. So how will we speak about this lecture? We will speak about pylorospasm and we will differentiate it with hypertrophic pyloric stenosis. So all the lecture will speak about pylorospasm and see the differences between it and hypertrophic pyloric stenosis because it's important to us to differentiate between them. So in hypertrophic pyloric stenosis, we will have some anatomical changes. We'll have thickening of the pyloric muscles, while pylorospasm is a motility disorder without permanent structural changes. So the HPS is more common cause of gastric outlet obstruction in infants. Pyrospasm can occur as a functional, sometimes transit condition in pediatric patients. It may be seen in older infants and children and can sometimes overlap with GERD. So the etiology and the pathogenesis, it can vary. So it can be neurogenic or hormonal. So we will have some problems in the sphincter because of some neural inputs or hormonal like inputs. And it could be just transit dysmotility. Some cases are believed to be transit episodes of dysmotility where the pylorus intermittently contracts excessively, and it can be associated with other conditions like gastrointestinal disorders. The clinical presentation. So for the symptoms, we'll have intermittent non-bilous vomiting that may be projectile in nature. So we will have a vomiting that is non-pilous. So this is the pilous vomiting, just to keep it in mind. It's the dark green vomit. We won't see it in this condition. We will have episodes of feeding intolerance or regurgitation, abdominal discomfort or colicky pain. In severe or prolonged cases, weight loss or dehydration may occur. Physical examination. In HPS, we will have a palpable olive when we palpate the abdomen. Here will be absent. And the child may be like he will appear well between episodes. So for the diagnostic approach, we will use the ultrasound. Actually, the ultrasound is not conclusive for pylorospasm. We'll actually want to see it to see if there is HPS or no. So for in pylorospasm, the pyloric muscle thickness and length will be in the normal limits, while in HPS we will see thickening and changing in the structure of the pyloric sphincter. And yes, there's nothing else here. So upper GI series, occasionally used if ultrasound is inconclusive, it can show intermittent delay in gastric emptying. Manometry is a research used to measure the like how strong the sphincter is contracting. So it can also be used. And the clinical correlation, like diagnosis is often based on the clinical history of the exclusion of the HPS. So if we didn't have HPS, we will have pylorospasm. So for the management, conservative management will be enough actually in most of the cases, which is we will just do observation and supportive care. We will care about the hydration and the nutritional support, and we will do some feeding adjustments such as smaller, more frequent meals can be beneficial. Medical therapy, antispasmodic and prokinetic agents can be used as a trial because there's no evidence that they will be variable. And when to consider further intervention if symptoms didn't get better or worsened when we do the conservative management. And we have in HPS, the management will be a surgery because we have thickening and changing in the structure. The surgery is called pyloromyostomy. In generally not indicated for pylorospasm unless there is a clear evidence there are some structural changes. So the treatment for pylorospasm is conservative management, which is just adjustment in the food, and for the HPS is a surgery, which is pyloromyotomy. The prognosis. So pylorospasm is usually self-limited condition with excellent prognosis, and most children will improve with a conservative management. We will just do a follow-up to see the length and the thick of the pyloric sphincter, so there we make sure that there is no evolving to HPS. So here is a differentiating between pyrospasm and hypertrophic pyloric stenosis. So in pyrospasm, vomiting is intermittent and the pyloric muscle remains of the normal thickness, where in the HPS we will have a persistent projectile vomiting and a palpable thickened olive mass, and we will have changes in the thickness and the length of the pyloric sphincter. In the imaging, normal muscle thickness and length in pyrospasm, and we will have changes in the measures in the HPS. For the response to management, pyrospasm will respond to the conservative measures, while HPS won't because it needs surgery. Here's a picture for pyloric stenosis. As we can see, the thickness changed and the length also changed. Here is a comparison between the healthy and the pyloric stenosis. Pyloric stenosis is the hypertrophic pyloric stenosis, same thing. So this is the healthy sphincter, this is thickened, and the length differs, so it's pyloric stenosis. This is actually everything for today. Thank you so much for watching. I hope you found this useful. Have a great day. Goodbye.